All right, Red Nation. Today we're going to be talking about fixed versus variable P coming up here at How Radiology Works. On your system, you're responsible for selecting the technical parameters. Remember, KVP, MA, time. You can also use the automated exposure control, and that will actually select the exposure for with respect to the time, right? The automated exposure control does not select the KVP for you. The automated exposure control, it is possible using what's called anatomically programmed techniques to essentially select on the UI, essentially spine or wrist or knee, and a default setting can come up for the technique parameters, including the KVP. And what we're talking about now is, do we want to use a fixed KVP for every knee exam, for every abdomen exam, or do we want to vary that based on the actual patient, which is on the table or which is standing for you? Some advantages of using the fixed KV is that it's simple, right? It's dead simple. You just always use that same KVP for that same type of exam. And there's less chance to make an error in that case by changing things because you're not changing anything. The disadvantage of using the fixed KV is that you cannot compensate, especially for areas that have a lot of soft tissue and that could change a lot from one patient to another. If you're using a fixed KVP, you can't compensate for those changes in the total attenuation throughout the beam. The advantage of not using the fixed KVP is actual being able to, on a patient by patient basis, depending on the size, to fine tune and adjust for a more optimal P for that type of acquisition. If done properly, the variable KVP can help to reduce the dose, especially for people that are kind of on the outliers of the distribution, right? So a fixed KVP will be relatively optimal for your average patient, but for patients who are smaller or for patients who are larger, actually being able to use a variable KVP will help you to optimize the dose for those patients. It does lead to a slight increase in complexity of your technique charts, or essentially your lookups for the way that you want to assign these different KVPs based on the size. But it is something that is a good thing to strive for, is to be able to prescribe an optimal KVP for the given patient size after you first start with the given anatomical region. Then you can optimize for the given patient size using a variable KVP for your patient.